Okay, good afternoon, everyone, and thank you so much for being here one more time. And sorry for having a very dense program back to back. We tried to put the 2 days conference in a 1 day, so that's the reason we are trying to have back-to-back sessions. And the last session, great question raised in the first and the second sessions, and the last session we are trying to be kind of the voice of the customers, kind of how we can learn, how we can actually utilize all the information from the first two sessions and to see how hospital can react to this in viewpoint of the hospital, what they are doing. I mean, I'm sure they have something to share that, I mean, many of them are doing great job and we cannot measure all of them, but the point is how we can do the better job to either keep the hospital as they are doing great financially sustainable, at the same time improve the health of the community. For the last session, the focus would be nonprofit hospital, community welfare, and social responsibility. As I mentioned early in the morning, really we don't have a clear understanding of accountability, social responsibility. Those are the concepts that we need to take on deep to understand what's the specific ask for the hospital to do the job. I mean, sometimes, even when you're looking at the publication, there is less kind of conceptual framework type articles to explain what is really asked for accountability. Many different partners may answer this question differently. So those are the gaps we need to address. But in the panel, we are going to start with, I'm introducing all of the panelists. We have Dr. Santos, Tatiane Santos from the Tulane University. We have Nancy from Catholic Health Association. I'm speaking with Nancy more than a year to see what's the best way to go with this. Thanks so much, Nancy, for all the inputs. And we have a Deidre Griffith from BJC Health System. I try to find someone to help me with this, to be the voice of the hospital, and she kindly agreed to join us. Thank you for doing that. And Eva Stahl, I'm just start learning a lot from Eva, that they are doing great job, and actually the real impact. One of the good metrics to measure how hospitals are doing great job is to see how they can reduce in the patient parts of the bad debt. In the IRS data, there is a two type of information for bad debt. One is the overall, one is the patient part. And then my expectation is if there is a good charity care or there is a good financial assistance program, I expect to see the zero for that part. If there is no zero, there's something that we need to think about this. And finally, we have Robert Nelb from the American Essential Hospitals. Thank you for being here, all of you. I would like to invite Nancy to go with the first presentation, and then after that, Tatiane will help us, and I will be the last one, and then we go to the panel discussion. Nancy, floor is yours.
Thank you. Okay, I'm a little bit shorter. And I get the distinct pleasure of going after lunch. So hopefully you all had some form of caffeine or something that lets you stay awake. But thank you. I'm actually very honored to be able to have the opportunity to speak about nonprofit hospitals. There's a mantra that we use when we're doing our community health needs assessments, when we're setting up and planning programs. And what we always say is, nothing about me without me. So thank you for including me so that when you're talking about me or the nonprofit hospitals, you're actually including us in the conversation. So I'm going to go fast because I only have 10 minutes. I swear I'm going to get it all done. But I have a few key points that I want you to remember as we talk about this. So not-for-profit hospitals focus on people. They're committed to their communities. They their not-for-profit status is highly regulated. And their value that they provide to their communities, the people that live there, goes well beyond the spending, that quantitative amount that's on Part 1 of Schedule H. So, for those of you who don't know who Catholic Health Association is, we are comprised and we represent the more than 600 Catholic hospitals and 1,600 long-term care and other health facilities across the nation. We are the largest provider, our association represents the largest provider of not-for-profit health care in the nation, with 1 in 7 patients being served in a Catholic hospital every day. So, and for over 35 years, we have been and remain today the leader in not-for-profit community benefit. We provide information, resources, tools to assess, plan, and report nonprofit hospital community benefit, and we help all hospitals comply with their federal requirements and meet their missions, more importantly. So, and just to accentuate our long history, we have a long and trusted partnership with Congress. So back in the 80s, our colleague Julie Trocchio and other members of Catholic Healthcare at the time looked around, spoke to our members, spoke to other non-Catholic nonprofits, and said, how are we meeting our social accountability? And what we did was develop from that, they developed the social accountability budget, which had categories of social accountability and definitions of how to account for them in a standardized way. The hospitals took this up voluntarily to understand what they were doing and how they were meeting their mission. So in 2006, when the Senate Finance Committee said, you know what, we want to learn a little bit more, and they instructed the IRS to take the Schedule H and create it, Senator Grassley said, hey, here's Catholic Health Association's framework for community benefit, and that framework became the Schedule H. These categories, 8 categories of community benefit, hold true today, and the IRS and CHA are aligned and continue to be aligned. We were also very instrumental and a key partner in the development of the ACA and 501R requirements. So, now that I was in the weeds, I'm going to take us back. Does this look familiar? It's our U.S. healthcare system, or my interpretation as I was doing my slides. Right? We talked about this. It's not always coordinated. It is hard to navigate as a patient. There are many parties in the system, and while the system and the goal of it should be that everybody gets the care that they need when they need it, and that it's affordable and transparent, it's not always. But what I want to point out is, here we are, nonprofit hospitals, right? We're one small part of a larger system. Okay, so nonprofit hospitals, mission-driven nonprofits. It all starts with a mission, right? Whether you're Catholic, other faith-based, or secular hospitals, you started, and they started because they wanted to care for the communities. So you're looking at the picture of the Ursuline Sisters, the very birth of Catholic healthcare. Took them a while to get to start a hospital. They came to address the needs in their community. So that mission and the mission of every nonprofit hospital recognizes the dignity of every person, the common good of the entire community, and the special concern for those that are living in poverty and experiencing vulnerabilities and marginalization. Community benefit and how we consider this is an extension and a continuation of our founding missions. Okay, so as mission-driven healthcare, we put people and communities first. We are committed to our communities. We reinvest surplus funds in the health and wellness of our patients in the community, not shareholders. This is a distinguishing factor. We are more likely to provide services that are non-profitable because there's a need in the community, and we heard about that earlier. We do pay taxes. We pay payroll taxes, unrelated business income taxes, and others fees. We just don't pay income taxes, and in some places, sales tax or property tax. We are subject to all the transparency and quality requirements of any for-profit hospital through HHS and CMS. And we have additional compliance requirements from the IRS related to our tax-exempt status. The investments, as I'm going to show you later through research, just in community benefit spending, Schedule H Part 1, I could really nerd out on the Schedule H if you want me to. I'm great at parties, so anybody who has happy hour and wants to talk to me, I'm very happy to do that. And we can talk about the Schedule H. I might even be carrying a copy of it with me, and we can look through it. But it far exceeds the value of the federal revenue that's foregone because of the tax exemption. Oops, wrong number. Okay, so I said we're highly regulated. This is me. We've heard a lot about the regulations, but putting them up there, right? You've heard about the 501c3. Jill talked about that earlier. The 69545 community benefit standard, as it's always known, that gives us the characteristics of what a nonprofit hospital looks like, including providing care regardless of somebody's ability to pay, and that research and training our future healthcare providers. We have the Schedule H form that's based on our framework that's required reporting. That the Schedule H does take into consideration, you have to answer questions related to that community benefit standard and the 501R. The 501R questions are at the facility level. The 501R this is my representation. Remember, I'm not an art student, I'm a math and science person. But the community health needs assessment, the community building, all the other activities that are on the Part 2 and Part 3, the emergency medical policies, financial assistance, billing, and collection. These are all the different ways that we are showing our work. And all these requirements are well described. Happy to pull out any of the requirements and walk through you. I do want to make a point because the CHNA was talked about a lot. I just came from the National Association of City and County Health Officers. Actually, the meeting's ending right now, but I took one of our critical access hospitals that's out in Kentucky and their local public health partner to the meeting to share their diabetes prevention program because they have a wonderful partnership. And yes, they're lowering A1Cs. Yes, they're doing great work in improving how well and how long people live. But one of the great things that they're doing also that has far-reaching tentacles of health is that they're building capacity. They're building capacity in how they're working together, how they're doing and coordinating in these needs assessments and in the work. And it's expanding across their area in Kentucky and beyond. And we just shared it with the entire nation at the NACHO 360. We'll give you more acronyms today. So there's a lot of value in the CHNAs. And what's wonderful is that these are local. We know healthcare is local. And it lets that social innovation and those solutions innovate at the local level. So while we're talking about top-down regulations or top-down concerns, please let's not forget that local innovation. Please not forget nothing about me without me. These are wonderful professionals. I mean, there are thousands of people at this meeting with the sole purpose of making our communities healthier and better. You want to be inspired? Go to NACHO or APHA. Okay, so lots of questions. What is community benefit? So here's the regulations. Community benefits are programs or activities that respond to a demonstrated health need and seek to achieve one of these community benefit objectives. Jill, these are all from your slides, I think, these objectives, right? So they must benefit the community more than the organization. So it's not marketing, it's not for your own employees, and it's not the cost of doing business. It is truly for the community, and it's a demonstrated need. So what I want you to remember is if the program is not addressing a demonstrated need, it's not community benefit. So yay, here are the 8 categories. There is only one definition of what community benefit is. It's that definition that I just showed you. And these are the 8 categories. These are the ways we organize the different types of things we do to address health. Each one of these is important in improving the health of the community. In these categories, when you report, unlike the Medicare cost report, which can have some charges in uncompensated care, all of these are reported at cost. There's a cost to charge ratio. I think Keith Hurl's here. He could tell you how to do that. And Stephen, they are all the math accounting people on how to figure that out. But it's all related to cost. There is no charges. There's no margins in that. Some people will say not all of these count. And what I want you to understand is that sometimes they're doing that related to an issue or a policy that they want. All of these count are important in improving the health of community. Some people will say that charity care, so financial assistance at cost, charity care is also known as financial assistance at cost, that's the only one that matters. It's very important. What I'm going to tell you is that's a bellwether. Because as financial assistance at cost increase, it means people aren't covered. They're not getting the care that they need, and they're showing up in grave need. And so it's really a failure of us to provide care for each other. Okay, and Rob, thank you for these slides. We just talked about, right? We're on the verge of seeing an impact of HB1 and people losing their coverage of Medicaid. And so these are Rob's, when we're on the panel, I'm going to let him speak to them. And as Eva knows, there's a lot of medical debt, and thank you for sharing. However, we're seeing large numbers of people lose their access to health insurance because of this. There's going to be more, and people are limiting access to care, right? If you can't buy in, we heard a lot about that. This is causing greater strain at kitchen tables, and it's also causing greater strain for nonprofit hospitals who run at very thin margins. Not only is it about those losing insurance, it's about the amount that hospitals are getting reimbursed to care for these people. So this is a double whammy. And what we're also seeing with this is that, and Eva can talk about this, I'm not going to pretend to be as well versed as her, we're seeing an increased growth in people being underinsured. So it's not just the uninsured, it's actually the underinsured that are having a lot of problems. And I think that's where a lot of medical debt is increasing with people who have these very high deductible plans or they're not able to meet those. Okay, so here's the question. Is this really worth our investment? Do we really want not-for-profit hospitals? Yes, we do. We do because they provide services that other for-profits would not provide because they don't make money. But let's just look at Schedule H Part 1. Those 8 categories, $105.5 billion compared to taxes foregone, $54 billion. That includes state, local, and federal taxes, and it does include the property taxes. This is based off of an EY study that they have done every year for, I don't know, at least 4 or 5 years now, to look at this so that we can hold ourselves accountable to, are we doing enough, at least from the data of the spending, so as a country, we're getting a 2-to-1 gain. If you take in parts 2 and 3, so 2 is community building, and part 3 is where you have the losses on Medicare and the bad debt attributable to financial assistance. That means those people, and let's consider that we're under strain, we're having a medical emergency, and we don't have, maybe we're unhoused, and we don't complete our financial assistance application. Those are the types of dollars that are going into financial assistance attributable or bad debt attributable to financial assistance. It's not bad debt because every business has bad debt. So the impact, though, of not-for-profit hospitals goes well beyond that 2-to-1 to 3-to-1. There is wonderful value in having a hospital in your community, having it close by. I don't know about you, but ask any mother about where she delivered her babies, and there's a lot of loyalty to those hospitals. Our first dog was named after Beth Israel because that's where I had my babies. And I'm very grateful, right? So there's our primary charitable purpose. The fact that I can get to that hospital in minutes, and we talk about as cardiology, time is muscle. Time is life in getting to those hospitals. Then there's the Schedule H Part 1 community benefit, which we're having a lot of discussion on. And then there's the other investments in health and well-being that don't get recorded. Yes, we're major employers. And Healthcare Anchor Network, we're using place-based investments to address housing and build businesses that are not part of Schedule H, but they're having an impact in the community. Our environmental stewardship that we're doing to lower costs, the things that we're doing to not use anesthesiology drugs that have a negative impact on the environment. All of those are investments above and beyond that we do to make our world a better place to live for now and for tomorrow. So, oversight. Yes, it's the IRS, right? The IRS has oversight over our tax-exempt status. HHS, CMS, like any hospital, for-profit, not-for-profit, they're over our medical care. So my surgeon does my surgery, my tax accountant does my taxes, IRS is monitoring our tax-exempt status. And they have to, through the ACA, review every hospital. You don't get notified, they just review you. It's a desk audit. They don't like something they see, they call you up, and they have been calling up hospitals in the last few years. They're checking for your compliance with 69545, that community benefit standard, and the 501R. They're making sure that the forms are filled out. This has been for the last several years, I think at least 3, that it's an examination priority of that division of the IRS. The IRS is also responsible and required to make a report to the Congress every year of private, tax-exempt, and taxable government hospitals about their spending and what they're doing. Unfortunately, no one has seen the report since 2020. So we're talking about we need information so that we can make choices. We have information that we're not doing. So I encourage you strongly, ask for this report. Ask for a place in a report. We have the Schedule H. We have this. Let's all start from the same place of understanding and then figure out where are the gaps or what don't we know, and then talk about what makes sense to figure out what we want and how to do it without adding all these costs, without knowing the direction we're going in. I think that was some of the discussion in the last panel. So, and I'm gonna say, our goal shouldn't be, do we need more regulations for nonprofit hospitals or not? Listen, everybody can always be better, right? We're human, and the wonderful thing is that we're human, right? We make mistakes, but we care about each other, or we should. And our goal here should be that each and every one of us, our family, our friends, and our neighbors, all have access to affordable, high-quality care that they need so that we all can flourish. Not just some of us, not just those that are lucky enough to be born into situations where they can flourish. This is from our perspective, this is a human right? Healthcare should be a human right, especially in this country. So as we continue this discussion in this panel, with the goal of healthcare for all and access for all, and true access, right? Just because you have insurance doesn't mean you actually have access. I want us to ask ourselves, are we using all the information that's fully available now, or are we just not using it because it's not convenient? Are we asking questions of each other now, or are we saying, no, it's not easy, I'm not going to do that, and we're just going to make assumptions? And then if we do decide, oh, maybe we need more information or more regulations, let's see, is that juice going to be worth the squeeze? Is adding more regulations to nonprofit hospitals, and we saw that they were a small part, actually going to promote affordability and access, right? What is it that we're working towards? Healthcare for all or more regulations on nonprofit hospitals? I'm not saying we can't be better, but I'm saying what is the ultimate goal? So thank you so much for including me and having me at the table, and to be able to talk about something that I'm very passionate about. And so I'm looking forward to the rest of the discussion.
Let me see if I can figure this out. Okay. Hi, everyone. Thank you, Hossein, so much for inviting me to be here. My name is Tatiane Santos. And today I was asked to summarize what we have learned from states that are implementing community benefit policies as well as other larger accountability policies for hospitals, so that, hopefully it can inform the future of community benefit and I think more broadly, hospital accountability. I'm not going to spend time about the history because I feel like we have done a very good job in the earlier sessions. But one thing that I do want to highlight is that a question that has persisted through the decades is whether hospitals are making enough investments, right, in their communities to justify their tax exemptions. So, but for the next 10 minutes, and I will try my very best to stay within the 10 minutes, will be to really think about, moving forward. What does the future of hospital accountability look like? And this is really going to be anchored on state experimentation. So, in order to be, it's a blank, conceptual model right now, for me to organize my thoughts around, what are the key domains of this hospital accountability framework? This is actually the early inklings of a larger, more comprehensive hospital accountability framework that I'm building. So let me just populate all of this right now. The way I'm thinking about this, and this is really just ideas, and for the panel discussion that we're going to have, it's really around expectations, transparency. We've heard a lot about that already. And oversight, I feel like in that particular domain, that's where a lot of the policy levers exist. And I'll give you guys concrete examples of what states are doing. And then I feel like the other domains like hospital behavior, where, it's more for the researcher side of things. In my case, that's what I'm also interested in, is understanding how the policies the first question is, do they actually shape hospital behavior? And if so, how does it shape hospital behavior? Is it in compliance with the policy or not? And ultimately, I don't know why the slides have been a little off, but it was centered. Ultimately, I think that the holy grail of, hospital community benefit and all the conversations that we're having is, are these activities actually improving individual and community level outcomes? So let me give you some examples of what states are doing. And these are just some examples here alongside what we're learning, from emerging evidence. So in terms of expectations, what I'm thinking about are, more and more states now are implementing policies that are financial assistance policy requirements that, actually articulate how much, not how much charity care, hospitals are providing, but giving some guidelines about, okay, for free care, hospitals have to approve everybody who's making up to 200% of FPL, for instance. In those policies, there's emerging evidence suggesting that it does positively impact. So hospitals do spend more in charity care when those policies are in place at the state level. And also that, eventually the ultimate impact really that we're interested in is like, does it reduce medical debt? And there's emerging evidence also pointing in that direction. Now, nationally, we know that there's substantial variation in financial assistance policies by hospitals. I'm not surprised because the federal requirements under the ACA, they give a lot of discretion to hospitals to set these policies. We also know from the literature that hospital health department collaboration in community benefit planning, like the CHNA and the implementation strategies, that it actually, is associated with larger community benefit spending as well as improved community outcomes. And this actually, this collaboration piece has come up in the previous panels as well. Something that I think we have long forgotten, but I'm so glad that I heard this in the earlier panels, is that hospital governance, from research now that is almost 20 years old, that hospital governance does shape community benefit activities. Now, the evidence on community benefit spending floors is still emerging, and I want to be very specific about this because there have been some studies looking at this. I'm talking about the Oregon policy. I think it's safe to say that Oregon has one of the most innovative community benefit spending floor policies right now. So, the evidence is still emerging on that one. And one thing that I want to put in everybody's radar is that in addition to community benefit policies, I think there are other policy levers that can really build into this larger hospital accountability framework, such as 340B, policy proposals. One example that I'm giving here, there's a bill that Minnesota proposed that would require hospitals to spend at least 25% of their 340B net revenue on charity care. That's one example of these policies. So in terms of transparency, I'm thinking immediately of reporting, right? Additional reporting requirements. I think there's a robust literature on the impact of reporting requirements at the state level and their association with community benefit spending. Usually hospitals located in those states are spending more in community benefit. There's also emerging evidence on some studies, like it's a new generation of studies that are combining data sets from different sources to help provide a more nuanced picture about what hospitals are doing in terms of community benefit. So one thing that we are learning is that there's a community engagement guidance, right, to producing the CHNAs and implementation strategies. We do see that there is low, quote unquote, compliance with that community engagement requirement in CHNAs. However, the hospitals that are engaging their communities in these local health planning activities, they are spending slightly more on community benefits, especially the community health improvement categories. We also, some studies have linked data from financial assistance policies. And for instance, if a hospital is identifying access to care and targeting access to care as a result of those health planning activities, like the CHNA, that there is little alignment, between those activities. So the, CHNAs and implementation strategies and the hospital financial assistance policies. And I know that, hopefully this will come up in the panel discussion. Now, overall, I think that the evidence linking transparency requirements to community health outcomes, right, is still lacking. It's still very limited. And one thing that I want to put in everybody's radar is this policy in Washington State that actually requires hospitals to link their community health improvement dollars to priorities that were identified in the CHNA. The evidence is emerging there. In terms of oversight, there's not a whole lot that tries to understand or estimate the impact of oversight, policies on community benefit activities or spending. But we are observing, we are noticing that more states are using these mechanisms, oversight mechanisms to help align hospitals with actual community need or community priorities. So looking at this all together, the hospital behavior, compliance, and the other domains there are things that we kind of examine as outcomes in the research. But so that's my organizing framework. Now, when I take all of this in, and I just really briefly and grossly summarized the evidence that we have from state experimentation, and still using this organizing framework, I think there are some things, my gestalt of all of this is, One, there's a need to potentially modernize, the community benefit standards. So one example that I'm giving here is to maintain an open medical staff policy. Is that still relevant today? I'm not saying yes or no, but and there may be other things that we could revisit, like community representation in hospital governance. That is actually a community benefit standard. The other one is that I think that anything that we talk about in terms of policy could be tailored to hospital financial and operational capacity. And I think that some states are actually moving in that direction, like recognizing that not all hospitals have all the resources to do all the things under the sun, so really tailoring those expectations accordingly. Community benefit spending floors, I think I first and foremost would look to what's happening in Oregon. The evidence is emerging. There's always a risk of what we call the race to the bottom, right? The hospitals are spending more, they end up spending less, but then it's like the balance, right? How about the ones that were spending less, But Oregon is actually doing something quite different, where the formula does take into account how much hospitals have spent historically, so that at least they're trying to address that race to the bottom effect. Build on successful financial assistance reforms. I think there's quite a lot happening there, and charity care is not the only way the hospitals can give back to their communities, but it's a very important way, especially in the larger context of growing medical debt and growing uninsurance because of all the upcoming changes and things that have already happened. So I think also leveraging governance and community engagement in these community benefit activities as an accountability mechanism is also important. And then I think collaborative health planning. I think I did not want to leave that out because maybe there's a way. In New York actually does require hospitals to collaborate with health departments to produce the CHNAs and implementation strategies. And they actually have to choose 2 health priorities at the local level to target together. And some research has suggested that this is, it works. In terms of transparency, the first one, I'm going to leave it as is to revisit Schedule H reporting. There may be things that we don't want to collect anymore. There may be things that we want to add. So one thing that is in the proposal that was just put forward is to connect the identified community priorities to community benefit spending. I think that's something that Washington State is already experimenting with, so I'm kind of interested to see what happens there, and improved facility level reporting. For oversight, I think there are a lot of states that are implementing more robust oversight mechanisms or models. I think there's an opportunity to maybe explore or strengthen federal and state collaboration with, in terms of oversight. And I won't elaborate, maybe a question will come up and I can elaborate on this. There are some cross-cutting themes that I did want to get across. And I think Nancy made this point, and I've heard this in the previous panels, is one, that hospital accountability extends beyond community benefit spending. There are many other ways that hospitals are contributing to their communities. One thing, I don't know why the mark is on top of this, but one thing that is really missing from this framework that I presented earlier is enforcement, right? So are there consequences for hospitals that are just persistently non-compliant with this expectation for community benefit? The newly proposed HR 9504 primarily advances transparency. So when we're looking at the framework, the other domains are actually not being touched by this proposal, even though it's a step in the right direction. And there are non-CB or community benefit policy levers like the 340B program, maybe oversight of hospital merger and acquisition transactions. I think some states are actually taking it seriously as well, so lots to learn there. And then this is a point that everybody has made. I did want to put it here that all the health insurance disruptions are projected to impact hospital finances. So we really have to take that into consideration when we think about adding more to this. So I'm not going to read each of these questions here, but I do want to point out that this new accountability framework, I intentionally added enforcement as another policy lever. I think that is something that probably needs to be considered, right? So we can hold hospitals accountable to some of these expectations that can be quite ambiguous. This is all I have for now, so thank you so much.
Okay, I'm the last presenter, but before I doing that, I would like to invite my great panelists to join us here, Eva, Deidre, and Bob. I'm going to quick on this, just to have something to think about this. And the question is, how should the hospital balance their role as healthcare providers, community partner, and economic constituent? So this is a core question. And if you look at this, I think the hospital are provider, hospital are economic institution, and they are community partner. For this presentation, I'm gonna go just focus on the role as a community partner. And being a part of the community, it's not just their behavior, but it is really depends on how they are impacted by influencer, how they're impacted by the state legislation, how they're impacted by federal agencies. And if you look at and kind of not being mission-driven organizations, it's come up with some kind of internal limitation the hospital may have. And if we look at this slide, and these are very simple questions. We try to address one simple question, and I know what happened to my slide, same thing with you, Tatiane, so it's gonna kind of moving between different computers. I look at definition based on the Schedule H. Part 1, I including the bad debt, and looking at the 4 organizations: American Hospital Association, Catholic Health Association, HFMA, and CMS. And I just looking at the document we have and computed the level of community benefit. If I go, and this is the data for 2021, and if we look at the AHA, we come up with $120 billion. If I go with the CHA, excluding the tax, bad debt, we come up with $94 billion. If we go with the HFMA, we come with about close to the AHA, $5 billion difference. And that $5 billion is a huge money, but let's go, and if we go with the CMS, and including any possibility, based on the data, we come up with 76. If you want to be so conservative with the CMS, I should just need to include this, probably charity care. And the gap is $120 billion and $76 billion, about $50 billion difference on the way, based on different organizations who are influencing the hospital. And this is not only at the organizational level. There is also problem or maybe issues with the states, and there is no agreement on type of the community benefits we need to include. I mean, there is a Schedule H and the hospital reporting, but when you go to states and how they emphasize on this, we don't see agreements, right? So we have about 8 states overall, including the Oregon recently added. They set the minimum requirement for the charity care. But when you go to the rest of the community benefit, at least if I go to look at the bottom of this slide, there is no single state that include the bad debt as a community benefit. And that's a big difference between AHA measure and the state level. And you can see the rest of this. I mean, the most popular measure is of charity care. And for me, the charity is the most conservative way to look at this. And let's go look at this, and we go with the 3 different metrics. And the reason 3 different metrics is because there is no agreement on how we can measure the community benefits. We can go with everything report on IRS form. Still, we see 40% of hospital not contributing enough. They are benefiting more from tax exemption than being a provider of community benefits. If we just exclude the medical shortfall, it's now for about 40% of community benefits. We see almost 40% of hospital benefiting more. And if you just stay with charity care, so we see 80% of hospital. I mean, I don't say I agree or disagree with this, but this is just based on the data that 80% of hospital benefit more from tax exemption if it just stay with charity. And then what does it mean? It doesn't mean the hospitals are not collecting information. I believe they are collecting more than enough information. And sometimes they are large. I mean, I'm a data person. I think sometimes having lots of data is much more confusing than it's something like if you imagine that they hack the information for 7 billion population around the world, and then what do you want to do with that data? So it's happening with some of the information that hospitals are collecting. I'll give you an example here. And look at, for example, one of the community benefits is cash and in-kind contribution. My specific question as a researcher is, so who received the cash benefits? It is important to see how much money is spent, but for me, I like to see who received this cash benefit. Who received in-kind contribution? I just need 2 cells to report me, okay, of 1,000, 10, 0. I mean, that's it. So we just need to have the right information, not huge information. And then the next question is, should community benefit requirements evolve to better reflect current population health needs? If so, how? And I give you an example here. And this is the well-known picture reported nationwide. We have $1,500 billion as a hospital care spending. And I really don't need to go with a lot of calculation to come up with community benefit. 10% nationwide, if including the bad debt, is a part of the community benefit, come up with $150 billion. And per capita, per person, we have about $4,000 for the spending, $4,400, about $500 for the community benefit for nonprofit. And if you put together all the federal agencies, we have 277. If you come up with the household level, we have 11,000, 1,100, and 700. And what we can do with this money. And this is another slide. This is the cost of 4 major cancer treatment in the US. And we have overall new cases per year is about 700,000 cases. A number of deaths is 229,000, and then treatment cost is $265 billion a year. And what we can do with the community benefit money, if we can hypothesize this, and if we increase, and there is evidence shows that, okay, there is a theory behind that vaccine screening for the cancer is a very cost-effective approach to eliminate the cost of treatment. And imagine we can improve the screening to 100% in the nationwide. And we just need $879 per capita. So still we have much money to spend for the charity care to address some of the bad debts. And if you look at the COLI to measure what's the best way to go with this, we have cervical cancer is the most effective way to go with this, lung cancer, breast cancer, and the CRC. So this is an example. We can argue about this. Probably this is more in treatment, but this is one of the examples that we can rely on the hospital expertise because they are provider. They can do much better job on providing care compared to the way they are doing and asked by IRS to do this. Probably we should focus on making a better measurement, a long-term strategy, and improve social responsibility. As I said, we really need to define this and identify and address community needs, and finally, increase transparency. These are very few examples we can go with this to make sure that we can see more impact on the communities. I stop here and go back to the panel. Sorry to see me a lot today. I'm gonna go sit on the panel for the panel discussion. Okay, is it working? Okay, thank you, everyone. Let me start with Bob. Thank you for being here. So we have a good discussion by Nancy about how nonprofit hospitals actually shaping the providing of the care. And we also had a good discussion this morning about the tax exemption limitations and legislation, and also a presentation by Tatiane about the impact of legislation, right? So a good question has come to my mind is how we can utilize the public face of this in terms of hospital as a part of the public health, but not just the providing of the care treatment more specifically. How we can see the hospital as one of the main aspects of public health to address the needs of the community. Which type of the collaboration we need this? I think this is the lack of collaboration. I think we don't talk to each other more often about some of the important questions. So please go ahead. First introduce yourself. I introduce you well, and then go with the question. Thank you.
Okay. So let's start. Great. So hi, everyone. I'm Rob Nelb with America's Essential Hospitals. We represent actually both public and nonprofit safety net providers that have a safety net role in their community. It's about 6% of hospitals, but provide over 30% of the charity care. And I guess question, I mean, we've been, I think a lot of these hospitals have been part of their communities for decades and are really committed to that role. And it's been really encouraging in recent years, I think, because of the community health needs assessments, others about really extending care beyond the hospital setting and thinking about the work in the community. I think that's why I raised the question earlier about how, sometimes these efforts to try to link community benefit just to those facilities at the four walls of the hospital is sort of short-sighted and not kind of reflecting how a lot of our community care is working today. We just had a conference yesterday with some of our members who are, doing, for example, substance use disorder work in different homeless clinics in California. And I think it's been a real indication of sort of that partnership. Obviously, the hospital brings the medical part, but it, relying on social sectors and other folks that can provide other pieces and how we can kind of partner together, I think is the key part. One of the takeaways from the conference was sort of thinking about how those partnerships cannot just be transactional, like something you report on a form, but really thoughtful and build out over time. And that's where I'd like to see our focus. Obviously, having done a lot of research myself, I understand the need to want to get more numbers and different things. But there's some of that qualitative piece about how you're really investing in these partnerships in the community that is probably the most valuable part, even though we can't always quantify it.
Thank you. Anyone else want to address this question? Okay. Let me move to different aspect of this. One of the metrics we can see how hospitals are successfully addressing the needs of the communities is to look at probably one of the metrics for myself is how much we can reduce the bad debt in the community, for more specifically for the poor communities. Eva, looking at the area you are working on this, how do you see this? How hospital can help much more vulnerable population to at least get rid of the bad debt, the patient side, not the bad debt by the hospital side? Just move it on the right direction.
Does that work? Okay. Hi, it's great to be here. My name's Eva Stahl. I'm with Undo Medical Debt. For those of you that don't know what we do, we are a nonprofit charity. We use and leverage charitable dollars to purchase bad debt in bulk. So we do this from a variety of providers, hospitals included, but also physicians, practices, ambulances, and other entities, because patients struggle with all kinds of bills, not just hospital bills. So when we do this process of purchasing bad debt, which is relatively cheap, and I would say that a lot of our hospitals actually don't sell their debt, so this is the first time that they're doing it when they do it with us. We are able to look in those bad debt files and be a support to the system to help them understand who falls through the cracks. And I also just want to make sure that we understand that financial assistance is not a magic bullet, right? Like it's not coverage, it is a safety net. And it's also pretty complicated in the sense that a lot of it relies on individuals taking initiative. And so we also work with hospitals on practice change. So one of the things that they can do that we're seeing emerge in states to reduce bad debt is to screen people early. And they can do this without applications through something called presumptive eligibility, which estimates income and swiftly moves people into financial assistance, particularly very low-income people that might be hesitant to fill out forms or feel overwhelmed in their own sort of medical moment of doing that work, because it is work. So it's, and I think, too, it's also taking into account that many low-income people are already income verified, and so it's finding pathways for them to move quickly into that, through that process. So as Tatiana mentioned, Oregon is sort of, leading the charge in this area, trying to support its hospitals and doing this presumptive screening early. Delaware just joined, and North Carolina is actively doing this as well. And it's, it's certainly one way to support hospitals in moving people out of bad debt. There are a lot of reasons that people end up in the bad debt files. And while we talk a lot about the importance of getting very low-income people below 200% of federal poverty level, that was raised. That's the average or the typical threshold for financial assistance policies. I will tell you from our work, and we go up to 400% of the federal poverty level. Increasingly, I would say that more than half of our portfolio in the last year is from insured people. And that complicates delivering financial assistance because you need to actually, as a hospital, you have a payer, right? So you want to make sure that the services are paid for. But it also creates complication because many people can't afford the deductibles, which means that they're walking into the hospital essentially, we call it underinsured, but when they have those very high deductibles or out-of-pocket costs, that ends up being absorbed by the hospital system as well. So it's complicated.
There's a couple of things that, right, 200% is the average free care with 400% the average discounted care that people receive. So that's what, $132,000 for a family of four. Think of, I think that's generous. The problem is that verifying income is difficult. So one of the things we can do is help hospitals, especially through, right, we have the IRS who knows everybody's taxes. Like, how can we streamline the verification of income to actually help patients get through that financial assistance process quicker? The other thing is that the Medicare cost report, and I am not a Medicare cost report expert at all, but as far as the Medicare bad debt reimbursement, you cannot do presumptive eligibility. You have to go through a stringent effort of trying to collect those bills. So that process of being able to report that and get that back for a hospital disincentivizes presumptive eligibility. So that's where we could work to address some of the policies that are getting in the way of some of the goals that we have to help serve people and so that they have the health care that they need.
And I would agree that those are two significant barriers. And I think asking hospitals to be income verifiers is a heavy lift. So I think it's something that we have to acknowledge is that some of these applications look like Medicaid applications, but they're for financial assistance.
just want to again echo, I think that you see how this, we think as the community benefit nonprofit is just so related to these other policies that we have in place. And so I think thinking, obviously the conference has been focused on, okay, tax expenditures and how that fits in, but the role that all our other direct, coverage policies, work with insurers and things, I think that fits in. And I feel like we should almost be thinking of these community benefit reports as the canaries in the coal mine, highlighting we have this problem and we need to address it. But policymakers should be open to all sorts of approaches to really address, if we have a clear problem, how to get better solutions that'll work for more people.
Thank you. Deidre, as a person, you are in the first line of providing service, so you are dealing with everything. We are just talking about this hospital need to do this, do that. So how do you see them real, and what type of the challenges hospital may have if they want to do this?
We have a lot of challenges. First of all, it's great to be here. Thank you. I agree with the. Oh, you hear me? Is it on? Okay. Let's have a seat and a voice at the table. Deidre Griffith, Vice President of BJC Health. And just a little bit about BJC Health. We have about 48,000 employees across our service region, and we are the largest health system in the region. And so it's a privilege to play this role, but I also want to thank Nancy for representing nonprofit health systems, because I started my healthcare career in Catholic Health at SSM Health under an amazing leader, Michael Miller, who recently passed. So I just want to give that shout out to him. Back to your question. It's really difficult. Community benefit is obviously a very large area. We've talked about all of the categories Nancy has shared. There's financial investment, there's community building, there's cash and in kind. And it really is going to, it takes a very robust system of documenting and tracking, which is very difficult, especially the larger your health system gets. I would actually acknowledge that you mentioned we don't need any more data, but we do like to reflect our numbers as high as possible, and that's a challenge when you have not a high capacity for reporting. For instance, if people don't report, to you as the centralized coordinator for community benefit documenting, you cannot report it on your 990. And so can be missed opportunities for reflecting the breadth of the community benefit that we are contributing. Of course, there are instances where maybe there are mistakes and it's over-reported, but having been now in 2 large hospital systems leading this work, I'm 99% sure that hospitals are under-reporting their community benefit contributions, and that's just from lack of capacity to capture everything.
So let me go back to same concept. So IRS develop a list, right, and list that 9 main types. If you go to the community buildings activity, 8 more, 17 different type of community benefit. If you go to the section second, you're gonna include buildings activity. In the third one, the bad debt. So do you think, do we really need to measure all of them? You mentioned you have you mentioned you are under-reporting many of them. Which of the under-reporting measurement is most important to see this? So the point is, we are not trying to just address what IRS requested. The point is how we can ask policy makers or legislators to modify this. In a way, we can measure easier, at the same time see the better impact in the community.
Yeah. So I would argue that where we are least represented in terms of the work we're doing is the community health improvement services. So we know that uncompensated care, financial assistance represents the vast majority. It looks like that's all we do, but it's definitely not. But the the preventative type of work that we do under community health improvement services is the hardest to capture because, again, you have to know who's doing what. We have a 24 hospital system, and so I need to have folks at each and every one of those hospitals who are willing to take the time out of their busy days, who have other full-time jobs, to report to me or in our community, our CBISA reporting system exactly what they did that counts. They also need to fully understand what counts, and I'm sure, as Nancy knows, it's not easy. You got to keep educating people on what counts and what doesn't. But I would say that there's a lot of room for growth in the preventive services that we provide because someone, Dr. Anderson, I think, brought up earlier that our CHNAs don't reflect when you look at the way our expenditures, spending, because it's all in uncompensated care, but that is, we approach the CHNA as really a proactive, preventive process, right? We're always with the lens of what are the top issues that we feel like we could really help our communities prevent. But those uncompensated care numbers represents folks showing up at the ED. We're not going to turn them away. A lot of times when you're in the community having these conversations during the CHNA process, they're not saying, oh, yes, we really hope that next time I go to the hospital, I'll get care, or, I want to be able to go to the hospital more consistently. I'm sure they feel that way, but they're really talking about their environment and the social needs that they have. And so that is what is reflected in our CHNA priorities.
Thank you. Tatiane, back to your presentation, and then a Nancy presentation. So we have a Schedule H, and if this conference was 2 years ago, I would ask, okay, how we should go and measure the community benefit. But for today, I have a different question. Do we really need to have all of them, or we need to add something else? For example, do we need to just stay with these 9 main types, or no? What is the meaningful community benefit for today's environments?
That's a big question, I think there's some states that are, encouraging or requiring hospitals now to link and usually it's going to be the community health improvement spending to priorities that were identified in the CHNAs or the ones that are actually being targeted. I think that's even more relevant in the implementation strategies. I think that's a more, from my perspective, meaningful way of understanding accountability or assessing accountability of hospitals to their local communities, and also to really get them in a mindset that all of this should be working together. Whoever is working on the financial assistance policies, that's tied directly to charity care, they should be speaking within the hospital, and I think there are some ways to measure that. So just going back, one, I think, is linking the community priorities, community benefit spending. Two is, I think some states and like the newly proposed, bill is also asking for the number of applications, financial assistance applications that are submitted, approved, denied. I think it's a good way to understand, at least it's a next, step or generation of, maybe how we can measure accountability. Usually when I'm working and doing my research, I do not look at education and professions or, research, but I'm not saying it shouldn't be counted. I think many people would make the argument that those are also could potentially be meaningful. So I want to try to stay away from what should count or not, but I think some interesting developments that I'm seeing at the state level is really making hospitals think more deliberately about how the community benefit dollars actually relate to the community needs that they're already identifying through the process of the CHNA and other health planning activities. That's one.
So So I think all the categories are important, right? Because when you look, okay, now I'm going to geek out as a public health person. When you look at the social ecology of health, you want to be able to address health at all these different levels. We're focused a lot, though, when we're looking at the dollars on that part 1, line 7, column E, which is where the cash is, and then column F, which is where the percentage of expenses is. What we're missing, and a very important story, is some of those columns that come before that. And the one right before is talks about the money that you bring in. So increasingly, nonprofit hospitals are applying for and bringing grants into their communities to provide these services and these programs. $1 million, tons. I'm sure BJC is getting plenty of these grants. The untold story is that, yes, you have the total expenses of that program. You have to offset it with that grant income, so that the net then is, if I bring $1 million into my community, I spend $1 million on this program, I bring $1 million in for it, it's zero community benefit for the organization. So then you're going to tell me you didn't do anything. And I'm going to be like, no, look at those columns beforehand of all this money, that this program wouldn't exist if I didn't do that, if I didn't get that grant. And so I think there's some more digging that we need to do to actually understand, how is this happening? If you go and read the reports, you'll learn more. There's always tension between the tax person telling me don't write so much in the tax return versus the accounting and my comms person telling me tell the full story. And so there's challenges with that. I can't remember if the form is limited with the number of characters or not. It's not, yeah.
And I would just quickly add to that, there's the grant dollars that we get in to offset some of our internal programs, but then we do raise funds for external community, look at that, external community-based grants that we don't see any penny of it. But because of our robust philanthropic efforts and influence, having wonderful board members, we're able to raise those dollars and then do community-based grant making, which, again, it's redeployed into the community. We don't see any of it. We don't want to. We want to support our community, but we don't get credit for it in the 990.
Can I add? I just wanted to comment on, Tatiana mentioned that there are a lot of states that are now implementing changes around data for financial assistance. How many applications, how many completed, how many incompleted. I think it's really important to try to, and I think we're getting there at the state level, to move toward a space where this data is not like a gotcha, right? But it's actually a moment to learn and to adjust policy. And I fear that sometimes these conversations is it's finger pointing. And I think it's really important that we're beginning to build out more robust state policy around, it was mentioned today, like, can we agree that there's a floor around 200 FPL for free care? Can we agree that we shouldn't sue patients, right, or take them through punitive debt collection practices? We call them ECAs. And I think the more guardrails we kind of can agree on and set those up so that those data points really become more of a barometer, as Nancy mentioned, about what is really happening in our community around access and coverage. Because we can't expect the hospital system to be absorbing all of the failures of the insurance environment. And we're walking into a full storm, right, of insurance failure. So I think it's a really important moment to be how we use this data, when we use this data, and for what purpose, and show up in good faith.
Thank you. It comes to my next question, actually. When you're looking at the CHNA, and some of them is 600, 400 pages. And we are doing a research, ask AI to go through 800 hospitals and look at all of this information. It took 6 months with AI to do a lot of work, and I'm really not sure the type of information we have is good enough to make a policy suggestion. So let's imagine we are trying to make it simple. So imagine the IRS is just ready to change the Schedule H. Which element you want to add to the Schedule H to make it easier to measure the impact of community benefit on the population? Which element do you add or you remove from the Schedule H? And this is for all the participants in the panel.
I think it's, do you ride the bus or take your lunch? Like, that's the kind of question that you're asking is, it doesn't have an answer, right? Like, what's most, I feel this tension of, well, what's most important? What's the one magic bullet that's going to make us all healthier, that's going to give us the access that we need so that each and every one of us and each and every one of the people outside and that we encounter has the care that they need when they need it so that they can flourish. And so I want to be able to answer your question, but there's a tension of we really need to say, what kind of society do we want to build together? Do we want one where access to care is only available to a few? Or do we want one where we see the human dignity in each one of us, and each one of us deserves access to care? And if that's the question, then from that determination of what type of society we want, then we go and build the policies to make that happen. And humans are amazing, compassionate individuals. Once we decide on which way we go, we can make it happen. I see such wonderful innovation happening at the local level around these CH&As and what's happening when people get together to address needs. So I would, rather than look at which item, what type of society do you want to live in?
I guess I would say, think about, I do wonder to what extent we in DC need to have like one data point that's the answer for access in a community, because it's each local. So I think what's more important than having AI read everyone's needs assessment is that local community reads it, and that there's actually feedback about the grants and how we're shaping access to care in the community. That kind of thing seems more useful. So there's sort of more process things about not just having another report that IRS isn't going to release for years, but actually get it out in the community and have it be more ground up than top down. Where I do think that there is some need for here we go. Yeah. There you go. Where I do think there is some need for federal oversight is less about just the 990 and more generally about our access and payment rates. So things like Medicaid shortfall, I think, is a real problem. And as the graph is going to get a lot worse as $1 trillion is cut from the Medicaid program. But my previous role, I was at MACPAC, the Medicaid and Payment and Access Commission. We did a lot trying to get the data on better understanding Medicaid payment rates, how they varied, and different things. And the thing is, you need the data not just for nonprofit hospitals, you need it for all hospitals, right? And so there should be some better ways to better understand rate adequacy in Medicaid and address that. The fact that you're seeing so much in the 990 is an indicator that Medicaid payment rates aren't appropriate, but the better approach is to fix Medicaid than to try to get more from the nonprofit space. And then another area where I think more federal oversight could help, or something to better understand is, and this is maybe the bridge between federal and the local needs, is sort of better identifying those subsidized health services. What are the ones that you don't only lose money on Medicaid, but actually all payers? So things like obstetrics, behavioral health, some of the trauma care. These are critical for a community, but as a society, we haven't figured out how to pay for it. And again, I think the fact that you're seeing people try to address these needs on the 990s is again more of like a canary in the coal mine, that we don't have good ways to support these services, and need to think more about that. But again, I think the approach isn't the 990 forms in a tax agency probably won't be as good at addressing that as something like CMS or a healthcare agency.
Yeah, I was just going to say, I would just say there's a lot of context behind the community benefit numbers that most people don't see. I mean, we're looking at a lot of numbers on the board today, and there's a lot of stories behind those numbers, a lot of work, a lot of partnership, a lot of aligning efficiencies that we're trying, continuous improvement. So I would just say that we as hospital systems we do need to get better about telling the story of our impact. because we're not particularly good at. In fact, as nonprofit hospitals, we tend to want to be quite humble and, have a lot of humility around this work. But we do need to elevate our stories because we are doing a lot in St. Louis. We are partnering with all the hospitals. We are partnering with our local health departments. It is not easy, but we will not give up because it is the only way. And so in the end, I guess when we tell our story of impact, our only hope, it would be that it mirrors the community's story of our health system as well. And we have done our job to meet their needs and use our resources effectively.
A few more questions, but I don't like to ask, like to give time to participants. Let's go to audience. So please.
Hi, I'm Derek Jenkins from the Baker Institute at Rice University. My question is, we've had a lot of good discussion today about sort of tallying up all of the community benefit spending on Schedule H and comparing it to the value of the tax exemption. But I actually think that that's probably not like the relevant comparison. We should be thinking more about. There's been some mentions of like for-profit hospitals are also doing some of these things. Like for-profit hospitals are also providing some charity care. And doing some of the other 9 things. So really, I feel like what we should be, measuring the tax exemption against is the additional community benefit spending that it would not have been done if the hospital was for profit, rather than just comparing the total costs versus the total tax exemption. It isn't quite getting at if you were already going to do it anyway for for-profit hospitals, then we might not be getting the total cost, actually the benefit of the tax exemption. But then on the other side, I also think Nancy's presentation, and Hossein had it in there as well, makes a great point. Comparing these costs is difficult and also isn't telling the full story, where these are the costs to the hospital and we're still not really measuring the value to the community, like how effective these cost dollars are. So I guess my question is, it's a loaded question, but like in theory, we want to measure, how much more value are nonprofit hospitals generating than for-profit hospitals, and how can we compare that, that difference in value with, which of course there's no data we can do that with, like how can we better capture the value, the marginal value of nonprofit hospitals versus the tax exemption, instead of just comparing these costs?
So, right, cost is just one thing, and what Deidre said is it's the stories, right? How does this impact your life? Like, think of a time when you really needed your hospital and they were there for you. I think of the patients that I cared for. I think of the patients that you held their hand and the difference, or the times that my hand was held and the difference that made. And what about that mother who comes in preterm labor, that the hospital is actually there, that there's actually OBGYNs that are there within an hour. These are subsidized health services that you don't. And so that mom lives, and that baby lives, and they live without comorbidities because they had the care they need when they needed it. What about those trauma services that are available in your community? Those are things that it's hard to quantify, right? And we want to be able to do that. We want to be able to check the math. The issue is that these impacts and how they impact us and how well and how long we live is very hard to reduce to a number. My economist would probably disagree, but I'm going to tell you that there's a story there that's longer to tell, and that actually speaks to the human person and the respect that we have for each and every one of us.
Yeah, I was just going to add to this. So maybe research dating back to like maybe 1 or 2 decades now, this concept of profitable and unprofitable services, and I think you alluded to some of these, that they were not looking at community benefit, but the added benefit, like this incremental benefit, which I think is an interesting idea. That when for a nonprofit health system or a hospital, they converted to a for-profit system, that they actually it was really clear from the evidence that they were providing less of those unprofitable services that can then, lead to the stories that Nancy just had. So that's one way to look at that. And when I made the point that community benefit or hospital accountability goes beyond, the dollars spent, I think, that is what I have in mind. But then, I also want to say that, because I do a lot of mixed methods research, so I have actually spoken with a lot of hospital leaders. And while I have a lot of examples, just as I imagine, your health system of hospitals who are really going above and beyond to do a lot for their communities, that we also know that there's the other side of hospitals who that are not, they could potentially be doing more for their community. So I think it's like fine-tuning. How do you fine-tune the policy, right, to get everybody to be, contributing as equally as possible, right, across, communities, because I think there's a lot of nuance, and variation in how hospitals are doing that, and that's a question, the $1 million question, how do you fine-tune policy at the federal level so that it's tuned to the local level? One thing I want to say, I mentioned before, is that New York actually has required hospitals to collaborate with community partners and the CHNA. So they are actually producing one community health needs assessment, and they are required to choose two health priorities that were identified through the process to target together. And actually, some of my research, we've been able to show that it does lead to higher levels of effectiveness, especially, we were looking at overdose mortality, that when they were, jointly targeting opioid use disorder, that overdose mortality actually was lower in those counties where collaboration was happening. The reason why I'm bringing this up is because I think that, that's a kind of local, a more kind of granular policy making that can potentially make a difference, but we don't know if the experience in New York would actually translate more widely to other communities. But I think, it's just thinking a little more creatively instead of asking to collect more information, or hospitals to report more information in the Schedule H. Maybe there's something else there that is outside of that, to help, again, hold hospitals more accountable and to be able to maybe tell some of the stories without all the narrative, that might be very hard to get through, I guess.
Yeah, and I guess I just wanted to get back to your original question. I think about the value of this statistic of the, calculating the value of the tax exemption, which I know is really hard to do, and a lot of researchers have been diving in to do it. But, I guess from my perspective, I do see it as of limited value because a lot of our hospitals are, losing money, so they would have low income tax. But so it, and then as you see the property taxes more based on are you in a city or not, and things that aren't related to responding to the needs of the community. I think when we think about, measuring the performance of our systems, things that are more important are well, first, are you even breaking even, about and ensuring that first part of just even having a hospital there. A lot of rural communities, safety net providers are just struggling to keep the doors open. Second, I think is how you can be affordable, right? And so are you being efficient and extending, access to care for folks? And then, we can see the value about, are you really investing in the long term? And this is where we see our hospitals providing those services that are at a loss to the community, but also about investing long term. I think, the Steward Healthcare, private equity hospitals came in and, it's for-profit motives, and they just sort of gutted so many of these institutions. And as they've closed, a lot of our hospitals have sort of come in to sort of preserve access to the community. And it's been just so shocking how that the short-term motive, for the profits sort of undermined investment in some of these services that you really need. So that's more of the difference, I think, between a nonprofit and a for-profit, not just what you do in 1 year, but kind of that investing in the long-term mission of the community to have access for people when they need it.
I can certainly speak to that because I live in Boston.
Yeah.
And my kid had an asthma attack in the middle of the night. He was downtown, and he called me, and he said, I'm at BMC. But he wasn't. He was at St. Elizabeth's, and it's because BMC went in and purchased St. Elizabeth's to save its emergency room, which I'm really grateful for, because then my kid had an emergency room to go to at 1 o'clock in the morning. But just to pick up on your point, I think you make a really good point, because I also think about all of the community investment that comes from a nonprofit hospital into the community writ large, that you wonder, what if you live in a space, particularly in Texas, where for-profit hospitals are your only option, and maybe you have an under-resourced community with not a strong local health department. And we've heard today that often the hospital can step in and play that role. So I think it's a relevant, important way to look at it.
Larry Polsky, I'm from local health department here in Maryland. And so I found two quick comments, and then I have a question. One was when Hossein asked about how the 990 can be improved. I think for all of us who have looked at 990s, we know that there's almost no useful information in there. I have looked at my local hospitals and then went to the CEO to say, I can't figure out what you're doing based on this. Can you please show me details? And was flatly turned away. And so was the CEO for the Maryland Hospital Association that told me what I could do with my request to see more detailed information. I find that not a single person up there could give one thing that could improve the 990 is possibly telling that hospitals just don't want to be held accountable. And I think we can understand that. If people aren't going to hold any of us accountable, we're thrilled about that. But I would encourage hospitals to at least try to do a little bit better. And then the last question was asked about value, and the first response was, we can't really measure that. Of course you can, at least to some degree, and that it really should be about the mom having a safe place to have her baby. Well, I'm an obstetrician. I was in clinical practice for over 20 years. I'm on the Maryland Maternal Mortality Review Team. We should be embarrassed in this country about maternal mortality and OB services in this country. And hospitals now own a huge chunk of outpatient OB practices as well. And the fact that we continue to see rates that are 2 to 3 times higher than every other industrialized country in terms of maternal mortality, hospitals shouldn't be up there bragging about the services. They should be getting to work. And then my question leading into that is that when I look at Maryland's 990s, hospitals self-report a 70% indirect cost for their community benefit spending. So a huge amount of that money is going right back into hospitals' coffers. I think in the last panel, the term administrative slack was used. And so, my question is, should hospitals be solely responsible, to a point earlier, that I'm sure your hospitals partner with their local health departments to come up with their CHNA priorities, but the reality is that hospitals get to decide 100% how that money is actually spent. I don't get a say in that, and I'm sure local health departments in other states don't either. With enormous overheads for the money that gets spent, should at least some of that money be transferred, whether to public health agencies, to local nonprofits with low overheads who can truly do the work? Or are we going to get way more bang from our buck by organizations that were not formed to treat acute problems, but to actually work on community-based prevention, and where our overhead is capped at 10%. So, we would double roughly the amount of money that actually goes into the community versus the money that hospitals spend on community benefit spending.
So I would say I'm sorry that was your experience when you went to a hospital and they didn't want to talk to you about what they were doing and how they were participating in the community. I agree that's not an okay response, and that there are many hospitals out there, non-for-profits, that would gladly sit down with you and share what they're doing. The 990 is a compliance report, yes, for our tax-exempt status. The community health needs assessment, our implementation strategies, our annual reports, and in many cases, hospitals are doing community impact reports, are ways that you can get more of a story. Is it in one nice, neat place? No. What I would say is that let's get together, and what would you like to see? And how would you like to see that? Hospitals, yes, I agree that putting money into some community-based organizations, that's why BJC has their grant program, who are, where they're better suited and have the flexibility and the resources and actually the relationships to do that good work of providing social needs, addressing social needs. Many hospitals are using their grant dollars or what their community grant dollars, and they're based off of, they actually have to meet one of the community health need priorities that are in their CHNA and even to be considered to do that. And so they're actually asking community members to say, why do you need this money and how will it help? So it's not just random doling out of money. Could ways that we do things be improved? Yes, let's talk and have a conversation about what you'd like to see. And again, I'm very sorry that that was your experience. I think any of the hospital people that are here today would be like, come sit down with me and then we're happy to talk about it, because the commitment is to the community. So I'm happy to talk to you. I'll give you, like, let's have a phone conversation, because I want to learn more and I want to learn how we can improve how our hospitals are supporting community.
Yeah, and I think you may be surprised to the extent to which hospitals are investing in community-based organizations and through our operations dollars as well. We are very clear that we are not, I do have experts in community on my team because that's the purpose of my office. However, we're not the end-all be-all and cannot address every social determinant of health, every social need. And so we heavily rely upon, again, those experts in the community who we know are doing great work, and we strategically partner with them and we strategically fund them. But it's hard to, again, see that context and that picture, that whole picture in the 990, which is what most people are looking at, without a lot of background. So it's just where we are. But we got to do better about our storytelling.
Sure. Oh, someone. Can you please, Paul?
Hi, thank you all so much. I'm a physician, an emergency physician at Johns Hopkins, and so this is all very new for me, and I've learned a ton today. I wanted to piggyback a little bit on what Dr. Polsky said, because I'm an emergency physician, and emergency rooms departments are included as part of what's required for the nonprofit hospital status, as has been reiterated today, but OB care is not. And both profit and nonprofit hospitals are increasingly closing their OB units, including one in Maryland recently, which means those parents are going to be coming to our emergency departments to deliver babies. And I delivered exactly 10 babies in residency 150 years ago as part of my graduation requirements. So the next time somebody comes in and I have to deliver their baby, I have technically done it, but I am not the most expert person to do it. And this is I hate it when people tell a whole story and don't ask a question. Everybody's done such a good job of asking questions. I feel like before we go to these community benefits where we hold health fairs or have partnerships in the community, we have to make sure we're providing the necessary health delivery services, whether that's a profit or a nonprofit. But the nonprofits are what we're talking about today, and I think most of them are mission-driven and well-intentioned. But how do we come back to these core principles and make sure we're providing the essential services before we even worry about whether we're doing all this other things, if that makes sense?
No, very much, and we're called essential hospitals, but it's rooted in these sort of essential services and really defining those core pieces that you need, and so hospitals are providing. And I think this is the conversation we should be having: is can we identify these access gaps and try to figure out how to solve that? And I think that's my solution, rather than add another thing to the 990. How can we learn from the needs assessments out there and really identify and address these issues? We've been part of legislation to really try to address the maternal health crisis, but it's not. It's things like increasing Medicaid rates, and our hospitals have been partnering with rural communities to provide access for those more complex cases and different things. But and I think I meet with our emergency department physicians. They're again this canary in the coal mine, seeing the problems, but realizing you can't actually you have to address it outside of the ED and engage in the community. But I think a more focused conversation about specific services would be more productive than when we just treat hospitals in a big, broad category. That's where it's amorphous and hard to sort of think about how to solve problems, because each service is going to have its own unique issues and ways to approach it. So thanks for sharing that. And I'd love to keep the conversation going on some of these essential services.
Okay, thank you so much. We actually connected this session to the next one. I'm going to borrow all of your break time to the very end, and then let's join me thanks our panelists and for great conversations.